WCLN 1170 Radio and Cable Channel 16 are pleased to present We Should Know, hosted by JW Simmons, an upbeat, informative look at people, places, and issues facing our community. This education-based analysis of issues will remain positive and informative as we consider closely what we should know.
Welcome back, ladies and gentlemen. We Should Know is on there. I'm JW Simmons, your host today. We look forward to having you each and every week on Tuesday at 2:30. There's a replay at 7 p.m. Tuesday, Thursday on Star TV. We come to you on WCLN radio and Star TV on Tuesday. The replays are for your benefit in case you happen to miss us as we air on Tuesday. Also, keep in mind this show is uploaded to YouTube and all the social media platforms after it is produced. I'm excited today to have our guest. Our guest is Dr. Christopher Kelly. He receives his medical degree from Columbia University, Physicians and Surgeons. He was one of those people that was academically achieved. He was valedictorian. He served as an interim resident, chief resident, and fellow at Columbia University Medical School. He's also been published in the New England Journal of Medicine and other medical journals as well. He has been writing for the Washington Post, been published a number of times there. And Dr. Kelly, let me thank you for taking time out of a busy schedule. And I can only imagine at Rex, where you are now, one of the premier, not only medical centers, but North Carolina Heart and Vascular. Thank you for being with us.
It's my pleasure to be here. Thanks for having me on.
Let me start this conversation. Two things. I want to talk about this book.
Of course.
I found you and your colleague, not only was this book timely, although it was done a couple of more years ago, it is so timely for today's world.
Yes.
I was fascinated as I looked at it and I thought, my gracious, how could we actually get this on the web so people could research it? But it would be nice if folks would buy this, and that would be helpful as well. But I want to talk about that. But the first thing I want to kind of pose an observation is help me let folks get to know you a little bit. What drew you to the Triangle and to North Carolina from New York and from your tenure at Columbia University? What was that attraction point that caused you to decide, well, I want to go to this place called the Triangle in North Carolina?
Yeah, so as you point out, I am not a native North Carolinian. In fact, I lived my entire life in New York City until relocating to the Triangle area about 2 years ago. And certainly growing up in New York City was very interesting and exciting in many ways, brought many challenges in others. Obviously, everything is more compact. You don't really have much room to stretch out and run around. I had a great time at Columbia University where I got everything from my undergraduate degree all the way through to my cardiology fellowship training, and really enjoyed learning there. It's a world-class hospital, and we deal with some of the most complicated, challenging patients that exist. But when it came time to really just think about the rest of my life and where I wanted to practice medicine and raise my family, it sort of seemed like New York City was not that place. Wanted to move somewhere where, let's say, the people are a little friendlier, where the space is a little more wide open, and where I could just start a new chapter fresh. And so my wife and I literally pulled out a U.S. map and we looked at cities all over the country. And seemed like the Triangle area, and Raleigh in particular, was just a great place to live and work. And people seem to love it here, and it's growing rapidly as a result of that. The word has clearly gotten out. And so we moved back. We moved down here, and it's been wonderful, and we haven't looked back.
Well, I can say it's our joy to have you part of our community, and we look forward for many years seeing you at hopefully at Rex at North Carolina Heart and Vascular, because that's such an important part of, I guess, to some degree, our environment here. Before we get into the book, let me ask you another question. It seems to me, over interviewing a number of doctors over the career of doing this, I keep hearing that statistically, there seems to be an escalated number of folks with cardiovascular issues, particularly in the eastern part of the state, which I guess could be linked to genetics, environment, what we consume, all of that.
So as a cardiologist, I am always busy. As you point out, the prevalence, the rate of heart disease is rising over time, unfortunately. And that's despite a lot of great medications and treatments that we have now that we didn't have decades ago to deal with it. The real underlying problem is the risk factors for heart disease are becoming more common. So people are getting heavier. People are experiencing higher blood pressure as a result of that. They're more likely to become diabetic as a result of that. Unfortunately, in various parts of the state, smoking is still pretty common. And so, as Americans on average get heavier, the likelihood of them developing heart disease becomes more common. A lot of that just has to do with the American diet and the food that's readily available to us, that's easy, tasty, and inexpensive. A lot of that just has to do with our lifestyles, and we've sort of shifted away, over the decades from a more active lifestyle to a more desk-based sedentary lifestyle. And with that, unfortunately, heart disease has become more common. Thankfully, people who do get heart disease are much likelier to survive it and live long, full lives than they were years ago. So although the likelihood of developing heart disease is higher, the odds of dying from it in the short term are lower, but it remains a major problem. And like I said, I'm always busy.
I remember having this conversation some years ago with a doctor by the name of Dr. Randolph Chitwood, who was instrumental in the developing of this bypass process that you guys use. I'm interested in also talking a bit about that as we go on with the show today. Maybe we can get that in maybe our second or third segment. But I want to go ahead and open up with this book and chat about it. And it begs the question on the front page, am I dying? You and one of your associates authored this book. I'll go ahead and say I highly recommend folks pick this up. It's a easy read, reference guide. Let's talk about that in the sense, what compelled you and your associate or colleague to do a book of this nature, and how relevant did I find it? Unbelievable so for the time that we're in now, because many people are a little afraid of even going to a doctor's office.
Yeah, of course. So thank you very much for your compliments on the book. The book was written by me and one of my colleagues at Columbia for a few reasons. Number one, everybody has symptoms from time to time, right? Our bodies aren't perfect. They're going to occasionally break down in ways big and small. And part of the challenge as a human is to try to figure out when a symptom is something that requires medical attention or not. As you point out, in the current era, going to see a doctor is for many people a scary prospect. They're afraid to go out, potentially expose themselves to infection, although we take great care to reduce that risk in our office. And so, if something happens, they want to know, should I just blow this off for a few days and hope it goes away, or should I go see a doctor and get it checked out? And if I do need to see a doctor, how urgently do I need to go? So despite the sort of tongue-in-cheek title, am I dying? I think a lot of people actually wonder that, like, I feel more short of breath today. Is this a sign of a life-threatening problem? So the book is organized around symptoms. It covers about 40 of them. Each chapter is a different symptom. And within that chapter, we go through all the flavors of that symptom and help a person understand when they should, as we put it, take a chill pill and just relax, ignore it. It's going to go away. Make an appointment or go to the emergency room. And the other thing that really motivated us to write this book was the fact that people are very hungry for this information. We live in an era now where with the internet, we can find out anything seemingly in a moment's notice. And people and all of our patients are always looking up their symptoms online. But although information is around us all the time, it's not always good information. I think most of us have become aware of the fact that a lot of the information on the internet is wrong, misleading, sometimes intentionally misleading. And we wanted to create a resource that people could trust, written by two doctors, and that they could turn to when they have symptoms, and not only help themselves sort of triage what to do about it, but feel like they were getting high quality information that has no agenda other than to help them. And so that's what led to the book.
One of the things I found interesting too, and I'll call this to folks' attention, is that to me, there's three parts to the book. There's the content of a book, there's the index, and then there's the meat that's in the middle. Right. The index of this book to me was just wonderful, because I could think of a term, whatever it may be. I could find that in that index. I could go to the book, to the actual part in this book, page number, very simple to do, and I could check it out. And I felt validated when I did that, because I felt like I didn't need to fact check the source. It was there.
Well, thank you for saying that. We tried to make the book as comprehensive as we could. Obviously, we can't fit in every symptom a person could have or every scenario a person could face, but we tried to cover most of what the average person is likely to experience. And so we hope that people will turn to books like ours the next time they're trying to figure out what's wrong with them and whether they need to be seen.
Let's talk just a moment. We got about 2 minutes out before our first break, but I want to kind of introduce this subject. We may need to linger after to go into the next segment. But one of the things I've noticed that there seems to be more meetings going on now with docs like you and others using devices in which you call and do FaceTime or what have you. Are you seeing that has increased radically over the past 3 or 4 months? Is it pretty much the same? And the following question to those two, I'll go ahead and ladder this out, and we can, like I said, we can go, if we need to go to break, we can do that. But I want to kind of get a feel for how that is going to play out post-COVID-19.
Sure.
Is this something that has changed the scope of medicine?
Right. So I would say that virtual visits, meaning a encounter with a doctor conducted either over the phone or via a video mechanism like FaceTime, Zoom, or Skype, was almost non-existent before COVID because, people just didn't really see a strong reason to do it. I think young people were using it a little bit, but people over the age of 40 were really not. And starting with COVID, that all changed. I mean, we went to almost 100% virtual visits in the early days of COVID in late March, April, because we just didn't know how risky it was to have people in the office, but we didn't want them to fall out of care and miss, needed follow-up. So we were doing almost 100% virtual visits. Over time, we've scaled back quite a bit. Many of our patients are coming into our office, and we take great care to try to make it a safe experience for them. But we are still doing virtual visits. And I think that, as you say, there is a long future to that. And we can talk about that in the next segment about what role this will have going forward post-COVID.
Absolutely. We're going to take a quick break and come back and pick that up because I think it's a big part of where medicine is. Ladies and gentlemen, stay tuned. We'll be back in a moment. Call a friend. We're talking with Dr. Christopher Kelly. We'll be back in 1 moment.
Experiencing slow internet? If you have a fast internet package, the problem is most likely your wireless router. With more devices using Wi-Fi, your wireless router may not be able to deliver the speed and coverage you need. We now have the leading solution to enhance your internet experience. Using small devices in a mesh network, these Wi-Fi appliances cover just about any size home so that all your devices can operate to their fullest potential. Whole home Wi-Fi from Star Communications. Get the most out of your internet connection.
Welcome back, ladies and gentlemen. We Should Know is on there. I'm JW Simmons, your host, talking with Dr. Chris Kelly today via virtual communications. And what we're doing, Dr. Kelly, and talking back and forth today is a new world for the communication mediums as well. Large TV stations as well as small ones like us have adapted to this. We were talking about the virtual examinations and those kinds of things that you guys, as you just pointed out, has just radically increased. After COVID, after we're hopefully somewhere in the second or third quarter of maybe 2021, depending on what expert, if this continues, how will medicine look to the patient when they're talking to you? Will it forever change that? Drive time from Clinton area to Raleigh, so we don't have to hit that major traffic zone and we can do it from the comfort of our bedroom or home. Is it going to change forever, or are we still going to, obviously we're going to need to see the doctor personally, but how does it change and what does it look like from where you sit?
Right. As you point out, the in-person visit with a doctor and a physical examination isn't going anywhere anytime soon. But I think that virtual visits are also here to stay. The one of the very few good things about COVID is that it forced medicine to step into the future and get with the program with virtual visits, which I think doctors had been resisting for a long time simply because, what they were doing worked for them and they really didn't have a strong incentive to change it. With the COVID, pandemic, especially in the early days, we all went almost 100% virtual. And I think that because we were forced to do that, a lot of doctors realized that actually it's not that bad. And it has a lot of advantages, both for the patient and for us. visits are much more streamlined. It's obviously way easier for the patient to log on to a link than drive all the way to our office. And we can actually accomplish a lot during a virtual visit. I think that if you are established with a doctor already, it's great to do a virtual visit for an occasional check-in if you're feeling well and it's just sort of touching base and going through the checklist of things that you typically do at a follow-up visit. Likewise, if you have a minor issue like a rash or just a minor symptom and you want to contact a doctor and speak to them about it, a virtual visit might be appropriate. I think that if you have a complicated set of issues, a complicated set of symptoms, and you're establishing care with a new doctor, probably you're going to want to see that person in person, just because they need to examine you, and it can be a long conversation, and it's probably good to do that in the same room as the person. But I certainly recommend that people take advantage of virtual visits just to make their lives easier when it's for minor issues and routine scheduled checkups.
North Carolina Heart and Vascular has kind of set a standard of excellence in cardiovascular care and in patient care. And just having visited friends and others there a number of times in that particular wing, pretty nice operation, pretty nice setting there.
Thank you.
Is that something that we should expect going forward from medicine, to have much superior environment standards and those kinds of things? Or is it going to be unique in such a way because of cost and other things that we're only going to have a few places, as we have now, that we feel comfortable going to?
Yeah, I appreciate the compliments. We certainly work really hard to create a great patient experience that is not only safe, but also comfortable and modern. And I think that increasingly doctors and healthcare systems are understanding that patient experience is extremely important, that just delivering good clinical care isn't always enough. It has to be a comfortable experience for the person. We have brand new facilities here that we think are really great and we're really proud of. I can't speak for everyone else. It costs money to do, and the economics of healthcare are such that not everybody comes out on top, and it can be difficult, I think, for all practices to have new, clean, modern offices. But we just feel very fortunate that we're able to offer that for our patients and provide really good care.
So going forward, again, I don't want to swing too far into the administrative role, because I know you're a specialist in the cardiovascular area. But what do you see from where you sit? And you've had a broad experience from New York, Columbia to now North Carolina. Is medicine and the expectation of we the patients increasing on what we expect from our physicians? Are we pretty much stable in our thinking where a physician says A, B, C, and D, or do you feel more a sense of challenge from your patients now?
Well, in the good old days, when my grandfather, for example, was practicing medicine.
That may be me. I'm not sure.
No, you're much, much younger. You might have seen him. He was a pediatrician. You might have been one of his patients. I think there was a very patrician style to practicing medicine for a long time around the world and in this country, where you saw the doctor and they asked you a couple questions, maybe showed some interest in your well-being, and then told you what to do, and that was that. And certainly that has changed a lot over the past few decades. And now patients are rightfully empowered, and they're getting second opinions, and they're asking a lot of tough questions, and they're advocating for their health, as they should. So the relationship has definitely changed. The power no longer lies only on the physician side, and it shouldn't. And patients are sort of much more engaged in their health. Part of the reason that I wrote the book, Am I Dying, in the first place was just because it was an acknowledgement that patients are doing their own research. They're not just taking what their doctors tell them at face value. They're going home, looking up their conditions, looking up their symptoms, reading more about them, and trying to have a good understanding of what they're dealing with. And I think that's appropriate, as long as the information that they get is accurate and fair, and is not misleading them with an agenda to either sell a medication or a product or something else. So my patients challenge me all the time. I welcome it and I encourage it. And I tell them that if they don't feel confident in the information I'm giving them because I'm just one person. I encourage them to talk to other patients and other doctors and, do whatever they have to do to get comfortable to move forward. And that's totally fine.
I think you made a good point. When I look back historically, there was that time that you would go to whatever the doctor's name was in North Carolina, and they would say, you need to do this, this, and this, and you would lower your head, you would walk out, and you would either do that or not do that and suffer the consequences. But now folks are thinking, no, I think I'll check with somebody else before I make that move. Even to the point of like major surgery or whatever, they always want to. But what I get from you, Dr. Kelly, is there's not a sense of being offended by that. It's more a sense of empowerment. You almost sound like you're saying to your patient, hey, feel comfortable in doing that, and then if I can help, let me know.
Yeah, I mean, not all doctors view this the same way.
Yeah.
I will say some do get offended by it. I feel confident about the information that I'm giving to my patients, and I feel strongly it's the right thing to do. If I'm not sure what to do, I'll tell them, you could go either way on this. You might want to get a second opinion. But I think if you're going to have a big surgery or undergo something life-changing, you owe it to yourself to talk to another person in the field and make sure that there's consensus that this is the right thing to do. And I am never offended by that. I think that it's appropriate and correct.
There's an article, the Washington Post article I recall reading, and if I'm recalling right here, is that there were a couple of places on the internet that you felt comfortable for folks to go to. And notice I used the word a couple of places, maybe two. But is that something that you feel at ease in recommending if somebody wants to do research, they could go there? Is that a comfort zone for you as a physician?
Yeah, so on the internet, health information, just like any other information that you can find, is a very mixed bag. There is some very high quality information out there. For example, the NIH has a whole health library that is very high quality. The American College of Cardiology for heart-related issues has a lot of good content. And then a variety of different universities, including UNC, have information online about health conditions and symptoms to guide patients. But at the same time, there's a lot of websites out there that do not have the patient's best intentions or best interests at heart and are directing them to a surgery or to a product or to a medication, or are just intentionally sowing doubt about certain things just for the sake of creating chaos. And, I think that we've all accepted that that's happening, for example, with political information online, but unfortunately, it also happens with health information. And so, just as with everything, I would encourage people when they go online to get information about their health to consider the source. Who is giving you this information, and are they a reliable source? I would not make major health decisions based on what some random person on Facebook says. I would consider, going to reputable places and getting their opinion, or seeing a doctor who you trust. But I would not take the information from anonymous people on the internet as high quality and follow it without further investigation.
Do you find that people are looking more if they have an issue, if it's something to do with the skin, they immediately look at a specialist, or if they feel a discomfort in their chest, they immediately look for the cardiologist? Is the general practitioner challenged in some way to try to still be the intervention mechanism before referrals?
I think that it's gotten easier for some people to see specialists, and with that, they just go straight to one. But I think that it's very important for all adults to have a good relationship with a good internist, because that person is really the best person to start with on most issues. First of all, because most good internists can handle most issues on their own without shopping you off to a specialist. And because many times people come to me without seeing their internist with chest pain that turns out to be a lung problem, or that turns out to be shingles, or something completely unrelated to the heart, and they really don't need my expertise at all, and an astute internist would have picked up on the issue and solved it for them. And so I strongly recommend that people maintain a good relationship with a general doctor, even if they are following the specialists as well.
We're going to take another break, and we'll be back in a moment. Ladies and gentlemen, stay tuned. We're talking with Dr. Christopher Kelly, an author, specialist cardiovascular at Rex. information you need to know, call a friend. Stay tuned. We'll be back in one moment.
You come out to replace a bad sensor, and that adds a 5-year commitment to my contract, and you don't tell me? Here's your sign.
Switch to the sign that's keeping homes secure and customers happy all over the area. Security from Star Communications. We pride ourselves on fair pricing and quick, friendly service every time.
Somebody trying to break into this place?
Security from Star Communications.
Ladies and gentlemen, welcome back. We Should Know is on the air. Again, I'm your host, JW Simmons. I want to remind you our connection with you is multiple ways. The best way to reach us is weshouldknowedu@gmail.com. weshouldknowedu@gmail.com. We're more than happy to try to respond to any questions or comments. We love the fact that you tell us what you thought about shows, no matter where you're located. If you're picking us up via radio, social media, TV, whichever platform you're picking us up on, we like to hear from you because we are hoping we're addressing and serving the needs you have. As an educational medium, we feel like our role, as we should know, is to educate and inform. And certainly one of the ways we're doing that is having guests like Dr. Christopher Kelly. Dr. Kelly is well-published, well-written, and to some degree, I often hesitate, Dr. Kelly, in using the term expert because sometimes it puts people in too much of a box. And when I look at some of the things you've done and your journey in medicine so far, you've got a pretty broad range of understanding in where medicine is. And I guess it just comes with the territory.
I work hard, but we're all lifelong learners. So as doctors, you learn that you can get humbled no matter how expert you and others consider yourself.
In having a conversation with a number of docs that are obviously far your senior, some of them senior to me, in today's world, I'm interested in some of the conversations in which I've had doctors look at me and go, given today's environment, I'm not sure that I would now, knowing what I know, I would not sure that now that I would choose medicine as my field of expertise. And part of that, those comments often come as a result of the financial climate we're living in as we look at healthcare for all and those kinds of issues. Do you have a sense of seeing that? Because when I look at anybody that's a doctor that has achieved that level of academic expertise, I know it comes with the weight of financial investment. Docs have told me sometimes it takes 15, 20 years to grind their way out of debt to medical school. Where are you at in that? And are we at the cusp of losing some of our best and brightest? It's troubling on the end of the receiving that I'm on because I want the best and brightest. Sure. I want folks that make a couple of million a year. That's great, but I just want the best people there. How do we balance that scale? Yeah,
I hear that a lot from some of my more senior colleagues. And I'm a third generation physician, so I've heard it from my parents and grandparents. I think that people have probably been saying that for a really long time. And I also suspect that a lot of folks who say that, if given the opportunity, would probably become a doctor again once they consider the other choices. Thankfully, being a doctor is still an incredibly rewarding career. It's still very lucrative for the most part. And you really, most importantly, just feel like you've made a difference in the lives of a lot of people. And it's very hard to get that in any kind of other job. But things are changing all the time. It's a volatile environment. Certainly, healthcare is a political issue and always will be. As we talk about things like Medicare for all or Medicare for any or a public option, it's not always clear exactly how that will affect doctors and, which types of doctors will be most affected by it. I think that, doctors will always be around. I think that committed people will always want to go into medicine. You are correct. I think that as the economics of being a doctor change, if the financial reward at the end of decades of medical school and training are not so high, you may see people shift into other careers. It's really hard to know. I feel very fortunate that I came out of my training without a lot of debt, like many other people have. And so for me, I'm not looking down, 10, 20 years of paying all that back. But unfortunately, I'm more of an exception than the norm. Many of my friends and colleagues had to borrow money from the very beginning just to get to medical school. And then, during residency and fellowship, you're not paid all that well, considering what you're doing. And so people do come in with a lot of debt that can be hard to pay back. And certainly anything that may potentially lower physician income, could deter people from choosing that very hard route.
When I look at Rex and some of our major hospitals in the area, and I also look at the smaller regional hospitals, as you're well aware, a lot of our small regional, what we refer to as independent operations, is pretty much closing the door. I think there's probably 10 more or less left in North Carolina that's not affiliated somewhere.
Yeah.
How do we look at medicine? And again, this is big picture question. As I told you before, we can go wherever you want to go with this. But how do we look at medicine to ensure that we're reaching those kind of disenfranchised communities? And when I use the word disenfranchised, I'm not necessarily choosing that as a word that would imply impoverished by any means, because sometimes disenfranchised could simply mean location in where you choose to live. How do we make sure we're reaching those people, and whose role is it? Is it a political role? Is it the medical community role? Is it the community's role in which you choose to live? It's more of a zip code question than it is anything else, I guess.
Right. And this is what makes healthcare so complicated, right? Because on the one hand, you have people who advocate for a total free market approach to healthcare. And there's some advantages to that for sure, but it is not something that can be treated like any other commodity, because everybody needs healthcare. You can live without a Bojangles in your neighborhood. You can't live without access to a doctor. So free market principles don't completely apply. And likewise, I think we as a population have not totally agreed on whether healthcare is a right and how much healthcare is a right, and what we as a population are willing to chip in and pay so that all of our, fellow citizens can have healthcare. I think these are very volatile issues that haven't been addressed. As for the issues that you describe about more rural healthcare systems, it's really hard. There's been a trend over the past decades towards consolidating healthcare systems. Large organizations like UNC, for example, taking over regional hospitals. That's done for a variety of reasons, one of which is that insurance companies are not paying small independent providers very much money. Because those independent providers have no negotiating power with those insurers. And so it can be very difficult to stay financially afloat for them. In contrast, if you join a network like UNC has a ton of leverage with insurance companies and can command much higher prices for the same services. And it allows those hospitals and offices to stay open. The problem is that, a centralized organization like UNC struggles to have offices in every town around the state. And likewise, this pattern repeats around the country. So clearly the current system that we have is not working for everybody, and something better is needed. Medicare obviously serves people over 65, and the variation in how much they pay is a little less, but there's a lot of people under 65 who live in rural areas who don't have Medicare. And I think one of the many challenges going forward is going to be trying to figure out, how much coverage we want to give everybody, what we're going to pay for those services, whether that pay is going to vary based on whether you get it at a small independent center versus a large, academic, healthcare system like ours. And those are totally unresolved issues, unfortunately.
And to some degree, a lot of the folks I've talked to include administrators, indicate to me that Medicaid is a big issue because, as you just pointed out, the amount that they receive from Medicaid is not substantial to justify even the equipment necessary for examinations.
I mean, the open secret in medicine is that patients with private insurance are already subsidizing everybody else. Private insurers pay much higher rates for services than government programs, more than Medicare, and certainly much more than Medicaid. And the only reason that the whole system works is because of that. And a lot of people rightfully have expressed concern that if we shift to a system where the government is paying for most people and the reimbursements for services go down, that it just won't be financially viable, at least not the way things are done now, for healthcare systems to exist. And that's a valid concern. And maybe we have to just think totally differently about how we deliver healthcare and how much it costs and what people expect from their healthcare. Especially at the end of life. We do a lot of things that cost a lot of money and yield very little benefit sort of in the last few months of life. And these are all very challenging, volatile, touchy issues that all politicians want to avoid and people don't feel really comfortable talking about. But eventually we are going to be forced to have a reckoning.
I totally agree. And I think one of the things that you just alluded to is very important for folks to understand is there's a lot of people out there, as you just pointed out, that've got minimums now like up $5,000-$10,000 before their insurance kicks in, and they do that. They tell me simply so they can have the policy to be able to cover them because the insurance premium is so high. If they don't do that, it's just not sustainable.
Yeah, a lot of people, unfortunately, as you say, have shifted to these high deductible insurance plans where they have to spend $10,000 before the insurance helps with anything. And those plans exist because the premiums are much lower than for plans where, more things are covered earlier on. But as a result, people are really not getting medical care unless it's a catastrophe because they don't want to be on the hook for all their healthcare bills. So they're sort of incentivized to ignore and delay things until they can't be ignored or delayed anymore. And you end up in the hospital with a massive bill that, gets partially paid for by the insurer.
And that in turn just makes everything else escalate in cost and price because you have to then engage the surgical processes and all those kinds of things that go into play.
It's a bad system.
So we're going to take our next break. And as we go to break, I want to remind folks that we are talking to Dr. Christopher Kelly. We are social platform or media platform today. We are looking at issues related to healthcare, folks, from the world that we're living in now, how that may be improved or changed as we go forward. And as Dr. Kelly pointed out, it's kind of like everything's on the table now, and there's a lot of decisions got to be made related to this. So we want to ask you to call a friend. We're coming up on our next break. Call a friend, family member, tell them to tune in. You want to see this, you want to hear from Dr. Kelly, and probably, Dr. Kelly, we'll want to hear from you again soon, but on this next segment, they definitely want to hear what you got to say. We'll be back in one moment.
To get the most out of your electronic devices, you need a strong internet connection and a protected home Wi-Fi network. You need high-speed internet from Star. Star has the fastest, most affordable high-speed internet service available for all your devices. We have no long-term contracts or high-pressure sales. Our service speaks for itself, and switching is hassle-free. We take care of everything with free installation from a local company. High-speed internet from Star. Internet at the speed of life.
Ladies and gentlemen, welcome back. We Should Know It's on there. I want to thank you for being with us today, as in each and every week at 2:30 on Tuesdays, 7 p.m. replays on Star TV, WCLN Radio, Star Communications, uploaded to social media platforms. We're talking with Dr. Christopher Kelly at North Carolina Heart and Vascular Center, UNC Rex Hospital in Raleigh, North Carolina. Dr. Kelly, thank you for being with us. We're on our last segment today.
Thank you.
Okay, the big picture thing I want to kind of drill in on here is the whole issue of what your specialty is, which is cardiovascular issues, which is the pump that keeps us all going in our lives, which is a critical component of what the listening audience and probably beyond this listening audience can get dialed into. The largest or number one killer of human beings today is still cardiovascular disease, correct?
Yes, correct. In the United States.
When we look at that, and I look at what you do, let's drill into current information today. Let's talk about symptomatic issues. We've talked for years about, diet. We've talked for years about pains in your chest. You talk about that in your book.
Yes.
But give us some idea of what you as a doctor would like to have your patients done before they are now in your office, or even more unfortunate or fortunate that we've got it, unfortunate that they are there, they're in a bed space at North Carolina Heart and Vascular.
Yeah, so a lot of my time is spent with people who have already developed heart disease, but what I wish I could do with many of them is go back 10 years earlier and help them prevent the heart disease from happening in the first place. And because, as you point out, heart disease is the #1 killer of humans and Americans, it's something that all of us need to be thinking about starting, in our 20s. So I think everyone should make sure that their heart disease risk factors are optimized as much as they can. So for example, you need to have your blood pressure checked once every year or two, starting in your 20s. And once you reach your 40s, it should be getting checked at least once a year, if not more. In addition, people should be getting their cholesterol checked. Again, starting in their 20s, just to make sure they don't have a genetic cholesterol problem, as about 1 in 200 people do. If their cholesterol is okay, good in their 20s, then they can, wait until their 30s again to get it rechecked. But starting around then, it's got to get rechecked every few years. You've also got to get screened for diabetes, especially if you have high blood pressure or if you're overweight or have other issues that increase your risk of that. And then finally, smoking, unfortunately, remains fairly common and is a major risk factor for heart disease, one of the biggest, in terms of the size of the effect, risk factors. And so if you're smoking, you really have to, do what you can to stop as soon as possible, because you are really just putting yourself at risk, not only of heart disease, but of lung cancer and many other medical problems. And if people really just took risk factors seriously and made sure their blood pressure was under control, that their cholesterol was optimal, that they were controlling their weight, we're not developing worsening diabetes or diabetes at all, and not smoking, heart disease would really go down dramatically in this country. But all the time, I encounter people in their 50s, in their 60s even, who just haven't really been following with the doctor and have totally out of control high cholesterol, high blood pressure, diabetes, and they're at the point already where they need heart surgery. Whereas if we had intervened 10 years earlier because, they had come to us asking for help, we could have avoided the whole situation.
When we look at a lot of these factors and we talk about our cholesterol, we also look at this picture of LDL and HDL, low density lipoprotein, and high density lipoprotein. We look at the balance in that, and at some point when all this is happening, we've also been tossed out for us as patients to look at our genetic predisposition.
Right.
Oftentimes that comes up in the conversation. Help us understand not only the makeup of cholesterol, but is there a gene somewhere that scientists are now looking at that can be corrected, tweaked, or what have you to help us lower that? Because I know folks, you do too, probably have patients that have the great glory of being able to eat cheeseburgers, whatever they want, and their LDL is below 100 and their HDL is like 75, which is So
yeah, your cholesterol is determined by a lot of factors that are under your control and a lot of factors that are not under your control. So the factors that are not under your control are your genetics, and people with a family history of high cholesterol need to be screened even more frequently and early on. And I deal with a lot of genetic cholesterol syndromes, and we can talk about that in a second. But it's also your environment. Your genes interact with your environment, what you're eating, how much you weigh, whether you exercise or not, how much alcohol you drink, and those determine your cholesterol also. As you point out, when you get your cholesterol checked, there's a couple line items that go into that. There is the total cholesterol, and then there's the components, the LDL. People say lousy cholesterol because it's the one that increases your risk of having heart disease or stroke. Then there's HDL, which is good, we think, and there's triglycerides, and there's some other things we look at too, but those are the main ones. So an LDL of greater than 190 or 200 is a full stop, somebody who really needs to be on a cholesterol medicine. Almost no other information is needed. Likewise, somebody who has already had a heart attack or stroke needs to be on a cholesterol medicine. Someone with diabetes most likely needs to be on a cholesterol medicine. For everyone else, we take the numbers and plug them into a risk calculator that takes into account your age, your gender, your other medical problems, and we can see whether your cholesterol is at an acceptable level or whether it needs to be treated. But you've got to know your numbers and you've got to get those checked. As for the genetics, you're right. Some people are just blessed. They eat whatever they want and they never get fat and they never have high cholesterol. And I wish I were one of those people, but I'm not. Whereas some people are triathletes, who are vegans and their cholesterol is through the roof. And I have many of them in my practice. And there are known mutations in certain genes, for example, the LDL gene, or other proteins related to LDL or to the receptors for LDL in the body that when mutated can make your cholesterol just go off the charts. And those are people who you get really frustrated because they say, I do everything right and my lifestyle is perfect. Why is my cholesterol so high? And I have to just explain to them that it's baked into your DNA and there's no lifestyle thing that you're going to be able to do other than taking medication to get it down. Maybe one day we'll have gene therapy and we'll be able to knock out the LDL gene in people. And, maybe we'll do that in everybody and just get rid of bad cholesterol altogether. But we're not there right now. So you've got to make sure that you get checked and that, you talk to a doctor about whether your cholesterol needs to be treated. I, in my office, genetically test people who have really, really high cholesterols. I genetically test their families and counsel them. And, it's 1 in 200 to 1 in 300 people who have a genetic syndrome. So even if you're the picture of health, that doesn't mean you're off the hook.
That's right on point. I'm thinking as you were making that statement, I'm recalling a study some years ago that Duke did as it related to cardiovascular issues, the psychological part of that, the behavioral part of that. There seemed to be some bearing also as it relates to whether we were a type A personality or not, those kinds of things. Are you finding there's continued interest in looking at that from a cardiovascular issue?
I mean, certainly stress and sleep can affect your cardiovascular health. And I talk to people about that all the time, not only because high stress level chronically can increase the acceleration of heart disease, but it can also trigger a heart attack. And so dealing with mood disorders and stress is also an important part of my job, and helping people get those things under control so that they don't accelerate the progression of their heart disease. You mentioned type A personalities and so forth. People of all stripes get heart disease. Unfortunately, you don't need to be a type A to have a heart attack. Many people who are total couch potatoes get heart attacks too. But mood disorders in general have a relationship with heart disease and certainly need to be treated.
A lot of conversation. I will try to get this in before we have to close today, but a lot of conversation about sleep, as it relates to everything from dementia to cardiovascular disease. What are you seeing as that relates to cardiovascular, particularly less than 8 hours, more than 8 hours? What is quality sleep from a cardiologist's point of view?
Yeah, so sleep is a very interesting topic, and you're right, it definitely interacts with heart disease. So the average adult should be getting between 7 and 9 hours of sleep per night. Unfortunately, many adults do not get that. If you are chronically getting less sleep than that, then your stress hormone levels are chronically high, and that can accelerate heart disease. Another problem that we deal with regularly, though, is sleep apnea. So this is a condition in which basically the airway becomes obstructed while you're sleeping. Usually this is because people who are overweight have a lot of soft tissue around their neck, and it actually squeezes the airway while they're laying on their back and prevents them from breathing. And they kind of suck against a closed airway for a few seconds, gasping for air, and then finally it opens back up. Sleep apnea is a major under-recognized problem among folks, especially folks who are overweight and who snore. And it contributes to high blood pressure and heart problems, heart rhythm problems, can increase the risk of a heart attack. So that's another thing. Even if you think that you're sleeping, the correct amount of time each day, if you're tired during the day and somebody says that you snore, you may have sleep apnea and should talk to your doctor about that because it can be treated.
We've covered a lot of particulars today. We're coming up on our last minute or so here. Anything that you want to add as we go to close the show today that we might have missed? We've got about 30 seconds.
Yeah, I would say only that, everyone's talking about COVID, obviously, and infectious diseases right now, rightfully so. But unfortunately, all of the other things that affect people are still happening. So make sure that in this challenging time that you're getting the health care that you need, that you're getting the appropriate screening, that you're seeing your doctor, that you're not blowing stuff off because you're much more likely to die of heart disease than you are of COVID. And that we should take COVID very, very seriously, but not at the expense of everything else. So stay on top of your health.
Well, I want to thank you for being with us today and taking time to come. And also, I'm going to go ahead and publicly open that door and say to you, anytime you feel comfortable in the sense of coming back and discussing key issues or even new findings, you have a seat at this table.
Thank you. Really
Ladies and gentlemen, thank you for being with us. We're closing the show today. We look forward to seeing you again next week. And we thank all of you for being here and being part of this show. And as always, we look at you and say, stay safe, stay well, and may God bless.
Thank you for tuning in to this week's episode of We Should Know with host JW Simmons. If you have a question, comment, or suggestion regarding this or any episode, please send your emails to weshouldknowedu@gmail.com. And remember to tune in every Tuesday at 2:30 for another informative episode of We Should Know.